Welcome back. You're watching DayBreak on this 16th day of June 2025. I'm in studio with Ken Gishinga, who is Chief Economist, Mentor Economics. Good morning.
Good morning, Sam.
Abraham Ochieng is the Senior Program Officer at Budget Hub. Good morning.
Morning, Sam.
And Dr. Nelly Bosira, Consultant Obstetrician, Gynecologist, and Health Policy Advocate. Good morning.
Morning.
And it's great to see all of you. Dr. Bosira, let me begin with you because last week, the National Treasury Cabinet Secretary, this is John Badi, presented a budget worth 2.29 trillion shillings and, of course, funding of different sectors. The most expensive one is education, but also you see a bit of allocation here and there. Counties are getting 405 billion shillings, and I was looking at the figures for the health sector, just over 130 billion shillings. What do you make of all these allocations? And, of course, realizing the context that you're in as a country and economy?
Well, I would say that it's been a lot of clawback in the health sector over the last 4 years, but I don't think we've been hit as hard by a budget as we've been hit by this one. And this is particularly because we're coming from a space where we are now grossly disadvantaged. I think we're all alert to the fact that we had a major withdrawal of donor funding in this year, and this is a donor funding that covers very critical health areas that we immediately needed to step in and be able to finance. And so for us to be able to cover the shortfalls of what the donor has left behind as a gap, the key target areas are really where we needed money the most. We're talking about HIV, we're talking about TB, malaria programs, we're talking about knowing that vaccines are next in line, and where we are sitting, we've had to deal with the fact that over the last 4 or 5 months, we have been talking about vaccine shortage for our babies, to a point where literally absolutely over 100,000 babies born in this country in the past 2-3 months are not vaccinated. So when we hear that we're cutting back on budgetary allocation for health, then obviously we are quite distressed. The second thing is that in the past, in the new dispensation that we have, we came up with the new primary healthcare funding, and maybe just to look at healthcare funding under the Social Health Authority.
Right.
What most people are not privy to, and this is quite interesting that Kenyans never quite read this act, is that we have the Social Health Authority oversighting 3 independent funds. The first fund is the Primary Healthcare Fund. The second fund is the Social Health Insurance Fund. And finally, the third one is the Emergencies and Chronic Diseases Fund. Now, to most Kenyans, all they know is that as an employed person, you're paying 2.75% to finance this. And what we don't understand is that the 2.75% and everyone else will be done for means testing and who will be paying independently of an employer is only contributing to one pillar, which is the Social Health Insurance Fund. So all the billions that will be collected from employers, from the paying Kenyan, are going to support only one pillar. And unfortunately, if we look at what the Social Health Insurance Fund is paying for, is actually pretty much going to be maybe at best, 30% of healthcare services. And why is this? It's because we have majorly pushed majority of care to the Primary Healthcare Fund. The Primary Healthcare Fund is paying out to level 4 facilities in this country and below. That means that in most counties, the only funding they will get from SHA is from the Primary Healthcare Fund. Now, the Primary Healthcare Fund is not financed by your contributions. It's financed by the Exchequer. So if the parliamentary allocations are not sufficient, or as we are getting used to the fact that even where allocations are made, disbursements don't follow through, then we are saying we've set up the Primary Healthcare Fund to collapse. Now, in the financial year 2024-2025, the allocations to the Primary Healthcare Fund was actually about 47 billion. We're closing the financial year and the allocations have not been more than 3 billion. What has been disbursed?
Was it? Because I remember at the budget reading by Professor Ndongo, he allocated some 4 billion shillings, but in supplementary budgets it was raised to about 7 billion shillings. The requirement is 50 billion shillings, but has never really been put in place.
We're trying to set up a fund that is expected to start off what starting off means is that at the beginning you're actually going to even spend more to put things in place to make this run.
Right.
Okay? Last year's disbursement was only 3 billion. Okay, this financial year that's ending was only 3 billion shillings. And where we are sitting, I think you've even had my colleagues who have been here, who have actually talked about what this is doing to primary healthcare services. That almost 90% of private healthcare providers are shutting down because they can no longer sustain giving services for reimbursements not given back. Secondly, the public health sector is not any far behind, because we are expecting that this fund should be able to take care of 80% of your need as a healthcare person. We're saying you only go to your level 5 and 6 facilities as a referral because your regular infection, your malaria, your respiratory infections, your pneumonias, your vaccinations, your hypertension, diabetes, and what have you, should be treated at your local level. And the local level is actually eligible for about 50 billion. But last year, as per the supplementary budget, when we're talking about giving 7 billion allocation, what exactly is it supposed to cover? How do you give 7 billion to cover what is expected to provide for, and not less than 50 billion? And remember, we've come from several years of cutting back on our health budget. And I'm not talking about whether the amount of money allocated is going up. We're talking about what is that amount of money as a total representation of the gross national budget. We are now at 2%, right? We were, maybe about 15 years ago, we were looking at 5+, 6+, and we were saying, yes, we're supposed to be heading towards the Abuja declaration of 15%. So we want to suddenly provide primary health care. We're supposed to be providing emergency and chronic disease care, fund care, and we are here not allocating the monies. How exactly do we expect them to work? What is even more difficult is the fact that even in the Act, it expressly states based on the availability of funds.
Yes.
So if the government of the day decided funds are not available, then what we're basically telling Wananchi, this so-called, we've talked a lot about giving you primary health care, is actually a farce.
All right, I've done the math. From 138 billion shillings out of a budget of 4.29 trillion shillings, it comes to about 3.2%. But then maybe there's an argument because counties, one of the key functions is health. There's an allocation that will go into that. But Abraham, does it make a case really when you have to reflect on the financing of the health sector, but also the demands for the other public goods?
Thanks, Sam. So I think just in line with that, the first point at which we should start is the functional analysis. So looking at who is responsible for what. So what is the national government responsible for, and what are the counties responsible for, and especially for some health, which is one of the most heavily devolved functions. And we are seeing the national government increasingly allocating more resources towards functions that should essentially be held by the counties, right? And one of the conversations that we've been trying to get back to is the Gazette notice by the IGRTC that was sent out in December last year. I think that would be a very good place to start, where we see they've clarified the functions that need to be conducted by the counties, and and once a function is assigned, then we expect the resources to follow suit. But we are seeing, whereas the national government has not taken any consideration into that particular Gazette notice. I remember when we met with the Budget and Appropriations Committee as well, we raised the issue because the Division of Revenue conversation, there was nothing to do with the IGRTC Gazette notice, which should essentially be the basis of all Division of Revenue conversations. But even as we see that, we maybe to specific examples, we're looking at the healthcare workforce, that there's an agreement between Ministry of Health, Council of Governors, that this should be transferred to the counties. But we know their contracts expire in May, I think May 2026. They're saying that, yes, we'll transfer the payroll and everything to the counties. However, we are not seeing anything there. The budget is very silent on that in terms of what does the county now take up, and how much more will be allocated to the counties to cover that, because it's just one financial year. What happens beyond May 2020, beyond this financial year, if once they transfer that, will that money be allocated to the counties? for them to be able to now take over that heavy burden, because we know health is really resource heavy. And so are we going to see the national government bringing that towards the counties to ensure that they deliver the health services? But also another point would really be on just the current budget. We are seeing the deficit that we saw in the budget, about 900 billion. Yeah, so that's a big, I mean, it's really heavy, quite far from what we saw in the budget policy statement and even the estimates that went into the National Assembly. And the biggest thing we know is that and it will be resource domestically funded. So borrowing will be domestic. So we are saying that once we are able to increase the deficit, then it means our repayments will borrow more and we'll be spending more to pay debt. And what does that essentially mean is that we are reducing what is available to be able to fund other social services, but even just run the government. Because if you're spending most of our money in paying debt, then clearly, and that's as a first charge, then it means that whatever is left for all other government functions, both national and county, then is very little. And therefore, we are likely to see more more services not being delivered as per the expectation.
And there's still a chance that this deficit may go up before the end of the financial year.
Yes, for sure. What we've noticed is every financial year, by the time the in-year increase to the deficit always increases.
Yeah.
So by the end of the financial year, the deficit is usually much higher. So, I mean, perhaps, who knows, we might even cross the 1 trillion mark.
Indeed, because we will hear of supplementary budgets coming in, Article 223 kicking in to finance emergencies and functions that had not been seen for the last 9 months that the government has been looking into figures. Ken, what is the bigger picture here? Because several sectors are demanding for financing, including education that has the lion's share of about 702 billion shillings, but still not sufficient. Why are we straining so much to finance critical sectors?
I think the big picture is what Abraham has really said about the budget deficit. And let me put that into perspective. When the PFA Act was passed several years ago, the idea was Kenyans would have access to budget estimates by early April and have at least 1 or 2 months to be able to discuss these things.
Yep.
If you look at the budget policy statement, it talked about a budget deficit of about 876. So a lot of our analysis has actually been pegged on that. And in fact, we were actually commending the government for the first time for reducing that budget deficit. Only last week to be surprised that we're actually seeing a bigger budget deficit. And what it does is exactly what Abraham has said. It means more borrowing, means the government is coming into the debt market, less money is available for the private sector, less jobs are created, and people now start struggling in terms of jobs, employment. So, and debt repayment is going to take up almost a quarter of this budget. So to the extent that we can fund critical services such as health, such as education, actually becomes into question. And if you think about the Kenyan economy,
yep,
human capital is our greatest asset. You know, unlike other African countries, we don't have the gold or the oil. What makes Kenya really stand out is its human capital. So your ability to have healthy Kenyans, knowledgeable Kenyans, is what makes us competitive. So for me, it's a big shock that that deficit has expanded to that point. I think our parliament has to at least order Treasury to revise it back, get it back to at least where the budget policy statement was.
And doing that means reducing the allocations to some sectors.
Well, I mean, you could actually play around with some of the key sectors.
Yeah.
I think there's some sectors where you could actually even postpone investments. But I think at the end of the day, it has to, the government has to focus on public goods and allow the private sector to focus on private goods. So I think Parliament has to come out very strongly and say, this is the time that we have to back the trend. This is the time where we need to get government borrowing less, so that...
Can it?
Yes, it is very possible, Sam.
I'm asking that because when those budget estimates were presented to the House at 4.24 trillion shillings, with a deficit of 876 billion shillings, after a couple of weeks, every department was heading to the committee to defend their budget. defense appears to have meant that more allocations. The National Police Service alone, 1.8 billion shillings extra. The Office of the Deputy President alone, 150 million shillings extra at Parliament. So how can Parliament win over the demands for more?
Well, I think if you look at both perspectives, both in terms of revenue raising, there are some sectors that have not been contributing their fair share of taxes, but most importantly, there's still sufficient wastage that we are seeing on the expenditure side, that there's still room to be able to reduce. So I think the most important thing for Parliament when they get this document is they need to look at that deficit and say, we actually need to turn around this ship, because remember during the campaign, the key talking point of the campaign season was when you're in a hole, stop digging.
Yep.
Yet we are digging deeper and deeper. So that's a big topic right now.
Okay.
Get that budget.
Do you take away the tools for digging? Dr. Ari, so the Cabinet Secretary in his statement, again, from the blanket figure of 138 billion shillings, he talks about some of those programs, including 17.3 billion shillings for the Global Fund. Help me here, what does that mean? 4.6 billion shillings for vaccines and immunization program, respectively. So where do these programs lie in the context of the financing models through the Social Health Authority?
I think what he was actually making reference to, Abraham made reference to the fact that health is largely devolved. And I think therein lies the fallacy. In healthcare, what is devolved is service delivery. Okay? I don't know any other ministry that has as many state corporations as the Ministry of Health. I think we have about 40. And all of these are at national level, and they must be financed at national level. When you talk about 18 regulatory authorities, when you talk about KEMSA, you talk about all of these monies is actually being drawn from what is left at the national level budget. So by the time you're talking to us about county level allocations are drawn out of what is, the counties have to budget for their health programs from the 15% that is allocated to counties. Which means that whether we like it or not, and whether we talk about devolution over and over and over, we're going to have to appreciate that. First of all, healthcare is a service industry. People don't go to the hospital to see the CT scan machine that you have put that's very fancy or whatever. They go to see a doctor. And for that ecosystem to function, you need health workforce in place. There isn't anything more expensive in healthcare than the health workforce. That's the highest budget. So most counties where they're sitting, they're struggling with allocating funding for healthcare, because in most places, if they have to be able to sufficiently pay the health workers they have, let alone the health workers they need, they're going to actually go in against the PFM Act. The allocations are going to bust. And in fact, the conversations they've even had in some quarters, it's to say, can we start looking at maybe human resource for health as a development budget now and not a recurrent budget, because it is really expensive. Then you come back to the national government that is running these programs you're talking about that have been very, very heavily funded, donor funded. We know that we have never sustained our HIV care. All these, please note that we have been dealing with HIV for over 25 years in this country. We have not funded that. We have been under Gavi support for availing vaccines for this country, which means that we only get to pay 15% of the cost of these vaccines. And not only that, that because Gavi has the bargaining power, the vaccine is already heavily subsidized by the time we're paying the 15%. Now, the moment we declared ourselves a lower middle income country, we then have to graduate out of Gavi support. That is how it works. So we actually are working against a timeline that by the year 2030, we will be paying 100%, and we may not be assured that the 100% cost we'll pay is at the price that Gavi is negotiating. So when we see a 4.7 billion allocation, please note that every other year we are expanding the vaccine cohort that we have. Just if I can just look at the last 20 years, we've actually managed to add maybe an additional 5 vaccines. And these are not cheap vaccines. So all of these are now what has been funded at the national level. And so when we talk about things like Global Fund, they're dealing with funding for HIV, TB, malaria. There's no Kenyan who pays for TB treatment. TB treatment is actually funded from the Global Fund. So these are not things that are going to sit and fit into SHA. However, if you look at the service it translates to at ground level, ideally this should be primary care. That's why we are here saying when we're talking about funding primary health care, we're actually not seeing the big picture. That vaccination is primary health care. When you're talking about prevention, that's what primary health care has been touted largely as, that we're moving into more of a preventive medicine space than a curative medicine space, because curative medicine is expensive. I agree. However, preventive medicine is not any cheaper. And what we don't understand is that it will probably take us 50 years of balancing investing in preventive medicine and continuing to invest in curative medicine before we begin to see the seesaw turn, and now the effect of what we are investing in now in preventive medicine in 50 years can begin to translate in reduced need for curative medicine. So we're talking about cancer care, and we are here talking about we need to vaccinate our young girls against the human papilloma virus so that in 50 years cervical cancer is not something we treat in this country. But at this point, we must invest in your radiology centers and all that, because that patient with cancer today still needs care. So when we talk about those allocations you're seeing there, they haven't addressed Mwananchi on the ground in the sense that Mwananchi appreciates. So when you look at what will the primary care provide, the PHC funding is going to do, when you talk to the service delivery point on the ground, this is where they're talking as basic things as lab diagnosis. Do we have an X-ray machine to diagnose uncomplicated pneumonia so that we can treat this person to go home? There are health facilities that even having a proper functional blood pressure machine is a myth. So we're talking about preventing it by expecting the community health promoter to check your BP on the ground, but he is armed with the BP machine on the ground, but when he refers you to the hospital for treatment, the nurse at the dispensary doesn't even have a BP machine. So when we're talking about when we're talking about balancing what is going to healthcare at national level vis-a-vis what is going to healthcare at the devolved level, we first need to separate the two and understand that they both need to be heavily funded. And a lot of the times you will hear counties saying, all the money for health remained at at the ministry level and we have nothing down there. We need to make it clear that what remains at ministry has no relation to the 15% allocation. And where I'm sitting, we've had devolution for how long now?
Since 2013.
Yes, so we're talking about 12 years. So 12 years ago, we started by allocating 15%. 12 years later, we are still allocating 15%, yet we expect the devolved services to have expanded and taken up their role fully. So where has there been the continuous allocation? And what they're asking, how are we going to strengthen devolution when you're not giving money to devolution? We focused a lot on saying, oh, there's corruption, and we agree there's corruption at county level. However, even what has been allocated, even without corruption, is still grossly insufficient.
So I had this question about when the cabinet secretary says, and I'm quoting verbatim, I have proposed 17.3 billion shillings for the Global Fund. Can he really do this?
You know, when you talk about the Global Fund, what we understand is what the donor brings in is not the only money that runs all these programs we're talking about. We have to match it by the percentage allocated to us. So we're only given money when we first invest.
So we give 17.3, and then what does the Global Fund give us?
So that has actually been contributing to 15% of what the Global Fund needs to give us. Are you understanding the billions that are going into HIV, TB care? So because we have not been pushing back so that we are taking up more investment while they withdraw, which is what we should have been doing for 20 years. So when the donors withdraw and that deficit that they're supposed to plug in is left gaping, we need to understand it's a huge deficit that even without shrinking our budgetary issues that we're dealing with, we really are not able to plug as easily.
Okay.
So we are expecting that we know our patients who have never understood how to pay for HIV drugs.
Yeah.
Interesting, even when vaccines were missing, those who could afford to pay were asking, where do I buy? And we're telling them, can you imagine that they're not available for sale in the private sector? They have never needed to be available for sale in the private sector. It is the same thing with our ARVs, that the private sector only invests in what it's going to sell.
Sure.
So if the population 100% is relying on getting this from government at donor funding backed by our own exchequer investment in the same, you can see where our gaps are.
And Ken, so as we talk about this, at the same time, there are shifting policies within the Social Health Authority, which has been on for a couple of months now, not yet a year, right?
Not yet. Not.
Okay, I don't know if it's, it hasn't hit a year. But you find that now the citizens who are paying monthly, the non-employed, or non-salaried rather, non-salaried Kenyans who are paying monthly, that option is no longer there. The Cabinet Secretary has been talking about Lipa Pole Pole, you get some loan from Hustler Fund. In the context of the economic realities, what does this mean for access to medical cover?
Well, I think that in the context of the economic reality, I think first it has to touch with what Dr. Bosire has talked about with donors funding shrinking.
Yeah.
I think the exact number the USAID has pulled out, I think it's about 82 billion shillings. That's how much Kenya receives from the USAID every year. So if that money disappears, even the 17 billion you're talking about in the Global Fund is way too little to meet what USAID was coming in. But I think from a broader perspective, particularly when it comes to SHA, I think it comes down to the structure of the program. One of the big talking points was on the Teacher Service Commission, whether they should be part of SHA, and I think there was a whole parliamentary discussion on why they have not been able to do it.
Yeah.
But I think from a broader perspective, we've never really answered the issue of healthcare funding. What's the most legitimate way for healthcare funding? I think that's a fundamental question we've never asked. We've always talked about universal healthcare coverage, but we've never really talked about where should that money come from. If you look at other jurisdictions, like in the United States, healthcare funding and education funding normally come from property rates in those specific areas. So if it's a particular county, let's say Nakuru County, it would be the property rates that fund money going into healthcare in that county. But we've never really gotten to that situation where we start ring fencing revenue for healthcare. It's all put as part of national estimates, which can easily dissipate. So I think we need to start ring fencing where money for revenue, money for healthcare and education should come from. And the United States has shown that property rates have been the most justified way of funding social services. And people are willing to participate because money is coming back to those particular jurisdictions. I think it's time to think out of the box in terms of our tax policy. How do we revise our tax policy, and how do we make it into a progressive tax policy that is able to fund these services?
Interesting. So then, for you, Abraham, what are the realistic options that a country would have when when these donors, or rather, they're lately called development partners, when they pull out their financing? What are those options? Because when you look at even the allocation to the counties, there's an amount outside the 405 billion shillings. There's an amount that goes there as conditional grants from the national government, but also resources from the development partners.
Please try again.
Not now. So what options exist for us to finance some of these public goods?
Thanks. So first, even before we get into that, I think something else we also need to consider is that the finance bill, which this time has not had so much conversation around, we're seeing with a huge deficit. For the first time in the last, I think, 4 or 5 years, the finance bill seeks to raise much lower than what it has been raising. And we are seeing the budget is increasing. So what does that mean? It just means, as we were saying, there's just more borrowing, but we are not seeing any effort towards efficiencies in what is actually collected. And I think even as we think about what options government does have, it's also to acknowledge that whereas the donors' support has been quite significant, and the government still puts in quite a big amount of money in terms of this deliver compared to what the donors are bringing, but also the challenge lies where we're seeing where does the donor money go to. It goes to the most critical, most visible things, such that if there's no money for vaccines, we can clearly tell that there's a problem. So for us, I think the government really needs to go back and look at what are we spending our money on. Yeah. So if we aim to provide basic services, then what are those critical? What do we need to cut back on in terms of efficiencies? We are seeing just this June more state departments being created. What does that mean in terms of even the administrative cost that comes with that? You'll need a principal secretary, an office, and everything that comes with a state department. So we are saying, how do we talk about efficiencies, but also we are still increasing the cost of running government. But also one other thing is a conversation, I think Dr. Bosire started mentioning that in terms of state-owned corporations, there's been this talk of consolidation, fiscal consolidation, over and over, but we are not seeing much coming out from it. We are seeing more state corporations still being there. We are not duplication of functions between these state corporations, functions that are supposed to be done by counties and that are being still conducted by national government. I think that would be a good place. Once this consolidation is done, then we should be able to see quite a significant amount of savings that can be utilized to deliver some of the essential services. So I think that would be just bringing closure to that fiscal consolidation conversation would be a good...
I thought you might actually want to say what you're saying. What is fiscal consolidation to the viewer?
So we have a lot of state-owned corporations that run different functions, and the challenge has been we see many of them have been doing the same, sort of like conducting the same kind of functions. Some that are even supposed to be done by counties. So we find that there's a lot of duplication. So we're trying to see how do we ensure that there's efficiency in terms of delivering of certain services. We are not just having different organizations within government conducting different services.
Okay, all right. When you read documents from IMF and World Bank, they talk about cutting back on expenditure, increasing revenue, or both. Well, there has been an attempt to increase revenue collection. I don't know why it becomes very difficult, Ken, to cut on expenditure. And as you do that, reflect also on the financing to other sectors like agriculture, which I think the budget talks about 47 billion shillings or thereabouts. Some have been saying that it's low. But again, reflecting on it as a devolved, primarily devolved function, what is the picture? What is the full picture of it at a time that you're saying we want to increase manufacturing, and much of our manufacturing is to come from the agricultural sector? The sort of investment that you're putting in this function, how do you look at it?
Before I talk about agriculture, Sam, there's a very important question you have raised about what is fiscal consolidation. And if you look at the graphs Treasury give us, they put it as a percentage of GDP, budget deficit as a percentage of GDP. And they'll show you a graph over the last 5 years, how we've come down from 8% budget deficit down to 4.5%. However, when you scratch beyond that surface and look at the number in absolute terms, it's actually that number is increasing.
Yep.
So it's a very misleading way. They'll say, yes, as a function of GDP, it's coming down. But in terms of absolute, we're actually about to hit $1 trillion.
Yep.
Now, when you talk about the crowding out effect, in terms of banks channeling money to government bonds instead of private sector, they're channeling absolute amounts, not as percentage of budget deficit. So we need to be very clear on fiscal consolidation to say, yes, it has to be as a percentage, but also in terms of absolute amounts. We want those numbers to start coming down. Otherwise, we'll keep going back to the same conversation where on paper, it seems like you're consolidating, but in reality, you're not really concerned.
And by the way, before we move away from that conversation, do you now have an agreement on what's the size of the GDP?
Well, the economic survey came out, I think, about 3 weeks ago. It talked about 16 trillion. But GDP is not the best indicator for an economic performance.
But it's the basis of the deficit percentage.
True. But GDP in itself has some inherent gaps. In fact, one of the reasons Kenyans always ask, how come our GDP is always growing 5%, but we don't feel it in our pocket? It's because part of our GDP is public sector funding on railroads, on infrastructure. And some of those projects are done by foreign entities.
Yeah.
And when they are paid, whether the Chinese or the Europeans or the Americans, money is repatriated back to those countries. So there's something inherently limiting about GDP as a measure. And that's why we need to also talk about these numbers in absolute terms so that we don't lose context. But to the second part of your question on agriculture, by all means, you know, Kenya has been a signatory to various declarations. Dr. Bosire talked about the Abuja Declaration on Healthcare, but even in agriculture, there's a Malabo declaration how much about 10% of budgets should be going to funding agriculture. Now, 10% of a 4.2 trillion budget should be about 420 billion going into agriculture, but we are seeing about 47, much less. And even in that 47, when you break it down, there's some things that are not quite, they don't seem like they really belong there, like settlement of the landless. You know, that sounds like something that should actually be under the Interior Ministry or the Lands Ministry. So one of the big problems when it comes to analyzing these budgets, we don't have visibility on below the vote heads.
Yeah.
What exactly, so when it comes to settlement of the landless, 3.8 billion, somebody might ask, should that even be in the agriculture budget? And what exactly is happening with that 3.8 billion? Is it, you know, that Narok land is going to be purchased? And people, you know, so it's that lack of clarity. And I've always proposed that once the ministry has published the national budget, individual line ministries should be able to come and say, for healthcare, this is what our further breakdown should be. So at least you have more visibility. Otherwise, you don't know whether it's on conferences, it's on workshops, it's on salaries. You have very little clarity on what we are discussing. But of course, it's the issue of the fertilizer subsidy program, which the government has been very keen on. But as I said, this is far too little. I'm not seeing enough on extension services, and that's where the real gap in our agriculture sector is, where farmers are not sure of the latest in terms of what they need to be doing. So for me, this was a very underwhelming allocation on agriculture. I think given that it's 22% of our GDP and can create the most jobs, I think this is a sector we should be able to actually even increase its allocation.
You know, I'm looking at what you're referring to, settling the landless, because yes, 47 billion shillings for the agriculture sector for various programs under this sector, and I mean it doesn't. Agricultural transformation and inclusive growth. So is this land supposed to be agricultural? What is the justification?
I tried to probe a bit further. It was unclear, and that's why I'm saying I think we need to get deeper into some of these numbers to really understand if it's purchasing of land by idle, absent landlords, or there's something to do with it, but it was not. But for me, I think the issue of the Agricultural Finance Corporation, the fact that it's not featuring here, for me, that is the elephant in the room. The Agricultural Finance Corporation should be getting one of the biggest allocations in terms of funding our agriculture, because the biggest problem farmers have is access to capital. Less than 1% of bank loans go to the agriculture sector because banks find agriculture very risky. It's very seasonal. You don't know if they'll get a good crop. You don't know where the pests. So banks avoid agriculture. And yet it's the industry that can create a lot of jobs. So the AFC was created to be able to be the avenue for agricultural financing. And in the 80s, in the 90s, the AFC was it was a major force of agricultural transformation. The fact that it's not even featuring among the top 10 for me is really an indictment on how far we've veered off in terms of our agriculture strategy.
Dr. he raises an important question about, you don't say much about extension officers, and across the country farmers are going on with their businesses, but much of the attention is just about subsidized fertilizer, and then thereafter you find some counties are having their own ways of ensuring they give minimum, what do you call it, GMR? What is that about returns?
Minimum market returns.
Guaranteed
market returns.
Guaranteed something returns. So different countries are doing that. But in terms of capacity building of farmers, you don't see it. At the Teacher Service Commission, when the parliamentary committees were looking into the budget of education, one of the things they touched is reduced the budget by 620 million shillings that was supposed to go to capacity building at a time we were dealing with the questions of implementation of the competency-based education. Talk to us, because also in the health sector, there's a requirement to upscale your skills. How important is it to take care of that component of skills of workers or people involved in a sector?
Well, I think with regard to the health sector, I think it's the one sector that was really a lot of very key functions were pushed towards, again, development partners, as you say. And I think when we look at budgetary allocations, again, the biggest challenge comes to translating allocation to actual disbursement. So you find that one of the areas that has really suffered has actually been what you're talking about, capacity building. And the reason then it does that is that at a devolved level, we're looking at counties being responsible for capacity building their own staff. We still have a heavy chunk of staff that work at the national level who are always being capacity built, again, by development partners, and it may not be directly in relation to what is going on the ground. But whereas things like education have certain time points that say we are changing into a competency-based curriculum, and therefore we need to capacity build our teachers. In healthcare, capacity building never stops. Healthcare technology evolves way too fast for you to think that you can do it there has to be a consistent, constant budgetary allocation. You bring in a new vaccine, you have to train all the way to the last mile the person who is going to give this vaccine, the person who's going to handle it, the person who is going to ensure that the cold chain is maintained. You bring in a new technology. You have brought in CHPs. We're saying we're expecting to be setting up community health units, which translate all the way to the ground to community health workers. MOH has actually now tried very much to use technology to do some of this capacity building by putting some of these trainings online. But there are things that must be trained and must be trained physically. And unfortunately, that is the most expensive part of capacity building. We're talking about putting up all of this fancy technology for care. It means it must be accompanied by training healthcare workers to implement. So when you say we need to put up 6 cancer centers across the country, I hope you understand that you need oncologists, oncology nurses, you need physiotherapists, a whole chain of command. It is not and that's why you'll walk around most counties and find that what we have specialized in is launching products, because people want to campaign based on things people can see, not on a healthcare provider available to them at their point of need. So we have launch of buildings, and many of them are not operationalized because the actual cost of operationalization comes back to capacity building. It means that we're sitting in a space where it's not enough to say I have graduated doctors, nurses, clinical officers, and all these people, but you're going to realize that for them to be effective, they need to be in constant state of capacity building. In-service training is very critical. And we say, oh, we have now we can stop postpartum hemorrhage. We have brought in carbetocin, wonder drug. It is going to stop women from dying. It's not going to be enough if the people who are supposed to use it do not know how to use it. And they didn't learn this when they were in school because it did not exist. So the space for capacity building is supposed to be a constant. And that budget has to keep growing as we continue to expand our retinue of services. The question is, as the economists are saying here, we have a shrinking fiscal space. Right. Where does it come from? The question is, what are our priorities? And I agree with them. We need to stop the wastage. We need to stop the wastage first and then refocus that on where it hurts most. So when we're sitting here saying we're rolling out things like primary health care, and when people say primary health care, the concept in most people's minds is that it is a cheaper version of health care. There's no such thing.
Yeah.
Okay? Just because you need to go and refill your medicines for hypertension at your local health center does not mean that now you have suddenly stopped needing to see the actual specialist who decides when does this medication change, when does the dosage go up, when do we screen your end organs to make sure they are not failing. That is not going to be handled by the nurse at the dispensary. That needs to be upscaled all the way to the level 5. So all of these people, it is not enough that the care is being brought to the ground, but the referral systems to build up to the top are making sense. So efficiencies in healthcare basically means, are we able to use our first line of defense workers on the ground in the most efficient manner? For us to do that, we will not only train them today, but will continuously and repeatedly capacity build them for what else is new that is coming in. And it's not just in the medical aspect of things, it's in the technology of delivering the medical services. It is the fact that we are now going online with a lot of the things we do. So we want to say, we want to have our information superhighway where we have a central database for all of our patients across the country. But are you realizing that the best surgeon may not be the most tech savvy? And for them to use that technology, they need to go back to the basics and be trained on how to use the online platforms. So the capacity building doesn't just stick to the profession. It actually expands beyond how do you best use the profession on the ground. And that is changing way too dramatically for you to think it can remain static even for a few years.
Yeah. Actually, talk to us a little bit about the place of consultants in this whole arrangement of social health authority. And consultants that are not necessarily with the public sector. Some are in private practice or in private hospitals. What is the position now?
The whole idea of actually most consultants will be in the public sector. This is what most people don't know. What they do is they make part-time in private sector, but the public sector actually has always been the sole employer of all doctors. So to be able to see this trend being reversed in the last decade like it has, is actually very worrisome. And when we are talking about consultants, we are talking about the highest available skill set at the top, responsible for clinical decision making. Unfortunately, they are also very expensive. And this is actually why for many years the government has allowed them some leeway to do private practice, because you cannot afford to pay them if you have to keep them full time.
Yep.
Right? So we're sitting in a space where we are assuming that primary health care takes away the need for consultants in level 4 facilities and below, which is a fallacy. This country invested so much money in learning from Cuba. If we all remember this, we had the Cuban doctors here. I can assure you there wasn't a single Cuban doctor in this country who was a general practitioner. In Cuba, by the time you even do as basic as family medicine, you are already a specialist, okay? So we want to duplicate the Cuba story in Kenya, whereas Cuba is using consultants, we want to use community health promoters. Because in Cuba, that person who goes to the ground and does a house visit is a consultant. Now, we are trying to assume that because we will have primary health care, and that's what I keep saying, healthcare is not cheap. It is never going to be cheap. You make concessions to make it affordable and sustainable, and by so doing, you are going to compromise on quality.
Right.
If you look at a high-risk woman going for antenatal care in the village, she's going to be seen by a nurse, right? But her outcome if she was being seen by the nurse compared to if she was being seen by the consultant is vastly different. And this is the reason why we keep saying we have invested so much in free maternity and all these things, but women are still dying and our maternal mortality ratios have never come down. Because what are we investing in? So consultants remain a cornerstone. My question is, are we using them as efficiently as we should? And what he's saying, when we're talking about reviewing some government policies and some government acts, maybe we need to also revise how we use our consultants.
Okay. Now, we need to close because you're running to 8 o'clock. Abraham, the essence of budgeting is not just to tick a box, it's also to implement it. Yes. If you look at various reports of the control of budget, every other quarter, we're always falling short when it comes to implementation, especially of the development budget and others, because exchequer releases are late. What must we do? Because we plan an expansive budget, we can't finance it, the cash flow challenges persist. What is it for us to do?
Sam, you're right in terms of the late disbursements to, especially to even the counties, but also, it stems from a deeper place. So currently, even we still have a stalemate on the division of revenue, just the agreement in terms of how much money. So that is already a contributing factor that will go into delays unless it's resolved earlier in terms of sending that to the counties. So that delayed of the delay in sending money to counties is a big contributor. But also, if you look at the basis for the money that is the equitable share, is on the approved reports by the Auditor General. So that also has, and I think we are currently using the
2020-2021.
Yeah, and so that's the approved. So there's been a growth. So if we can have that as changed, perhaps to consider utilizing the audited reports as the basis, that would see a lot of money going, and that would increase the amount of money that goes into the counties. But I also think that just being clear, both National Treasury and CRA, in terms of agreeing on the basis for division of revenue would be good. We would not be having this stalemates that also contribute to huge delays into sending money. So I think those are some of the key things that perhaps government needs to put into place to ensure that first there are no delays, but also the amount of money going to the counties is increased, because whatever the kind of growth we are seeing in terms of our revenue needs to also be put into consideration.
And on that particular point, who decided that we will be using 50% of the last audited and approved accounts? Because the Constitution talks about not less than 15% of all revenue collected by the national government. Yeah, so that's the other thing, interpretation. So people want to, I think there's, the government perhaps is just using the minimum to start off. But even as we said, as much as it's the minimum, we've been seeing that the absolute numbers are growing, but the percentage really remains, the same for that. So is it commensurate to the growth that we're seeing in revenue at the national level? And I'm asking that because, so the last gazetted size of the GDP, 16 by KNBS was about 16 trillion shillings or thereabout. But the government is not using that. It is using its own calculations or projections of the National Treasury, which now settle at 19.2 trillion shillings. And the funny thing is that if we are to use the numbers of 16 trillion shillings as published by the Kenya National Bureau of Statistics, then you'd find that the deficit is at 5.7%. If you use the figure they're using of 19.2, then you are down at 4.8%. I don't know why it's convenient for the government to use the unverified size of the GDP when it's talking about deficit, but when it's making an allocation to the counties, they use the last audited and approved accounts of 2020-2021. Ken, is there any explanation?
I mean, I think it's just chickiness, really. I think it's trying to present to the public one narrative, but also trying to maximize or minimize liability on the government side. And I think it's come out from a culture where maybe citizens didn't follow the budget as closely as over the last 2 years. But these are the things now that people are starting to ask questions about. So I think for me, it shows that now citizens are far more engaged, asking about these numbers. And I think this is the time now Parliament now should be clarifying, even if it's with that debt ceiling of 55% of GDP.
Right.
We need to start talking about absolute numbers, because it's very, very easy to get lost in that narrative. So for me, I think this is a good conversation to be having right now, and the government, especially Parliament, which has to play this role of inquiry. I think that's the direction we have to be going.
So when the Constitution says 15% of all revenue collected by the national government, what does all revenue mean? Is it ordinary revenue, or is the total revenue inclusive of the appropriations in aid?
The total revenue.
So if the total revenue is 3.3 trillion shillings, that is projected, and you allocate 405 billion shillings, then you're at 12.2%, which if you had to use that as the basis, then it flouts the Constitution. An uncomfortable conversation must be for the government. What are you saying on X? At Citizen TV Kenya, at Sam Gituko, the hashtag to use is Citizen DayBreak. Let's see, Franco Rinda is saying that the 2025-26 budget places key focus on critical sectors: education, largest allocation; health, UHC rollout; infrastructure, roads and housing; and agriculture. However, questions remain on fiscal discipline, debt servicing, and austerity versus service delivery. What else? Bobo Tiena, you're saying, on paper, government budget 2025 looks lucrative, but in reality, it's a pipe dream, and Kenyans will have to dig deeper to enjoy its fruits. Corruption is the enemy of development and of good governance. It must be gotten rid of. The corruption of the best... Okay, can I just finish reading? There we are. The corruption of the best things gives rise to the worst. Economic growth and development is being prioritized to favor the haves and don't haves carry the burden. All right. Sheila, no new taxes? Not really. Kenya's 2025-26 budget squeezes hustlers via aggressive tax compliance and slashes development funds. Cost of living crisis depends as government dances to lenders' tune. When Jiko bleeds, elites breathe. Okay. MC Rumaz, we want a police service that operates within the confines of the rule of law. We don't need a police force that is inhumane and acts like they are above the law. Police are being used by the political elite to crack down on dissenting voices. That's part of your feedback, and that one is on our earlier conversation with Irungu and Nora. Now, there's a question, a comment there by one viewer who talks about debt servicing. Already you're allocating money to service the interest and also redemptions, but at the same time, the National Treasury is waiting on the Auditor General to come and verify how much we owe. Thank you, Ken Gishinga. Thank you, Abraham Ochieng, and thank you, Dr. Nelly Bosire, for coming for us to have this conversation. We'll continue to focus into the budget 2025-2026. Tomorrow, we'll be drilling in on the education sector funding, the gaps, the challenges, and also the opportunities that the country has as we get deeper into the implementation of the competency-based education. My name is Sam Gituku. See you again some other time. Bye for now.